Dr. Ken Landau. Thanks for watching. Let's talk about Clozapine. Clozapine is also sold by the trade name of Clozaril. Also multiple different names associated with the drug. It was the first atypical antipsychotic marketed here in the United States. It was synthesized in 1956, FDA approved 1989, marketed 1990. It's on the World Health Organization list of essential medicines. It's specifically approved to treat schizophrenia and schizoaffective disorders. That's a combination of schizophrenia and affective disorders like depression. It appears to decrease the risk of suicidal behavior and seems to be more effective than the other drugs in the same class that are currently available. And it especially seems to be helpful for people who have treatment-resistant schizophrenia. It also can be used in people who have Parkinson's disease and its secondary psychosis. Off-label, it's used for those individuals who have violent or aggressive behavior, treatment-resistant bipolar disorder, and it's used in those people who have tardive dyskinesia. It seems to be that the Clozapine has a decreased incidence of tardive dyskinesia versus the rest of the family. Well, there's a tendency right now in the United States to use the drug only if other drugs fail. We call that treatment-resistant schizophrenia, defined as people not responding to at least 2 different antipsychotics given for a sufficient period of time at a sufficient dose. It seems the drug works best in those people who other drugs don't seem to work at all, respond poorly to. The effect of the Clozapine should be noticeable within the first 6 weeks. Now, in a study of 15 different antipsychotic drugs in 2013, treatment effectiveness of Clozapine was #1 in schizophrenia. There's some evidence it might be twice as effective as Haldol or Seroquel or Abilify, maybe 30% better than Zyprexa. Well, you can take the drug with food, without food if you'd like. Take it orally, comes tablet or liquid. The tablets are either 25 milligram, 50 milligram, 100 or 200 milligrams. Now they have an orally disintegrating tablet. It comes in the strengths of 12.5, 25, 100 milligrams. Starting dose is 12.5 milligrams once or twice a day. Cautious titration, cautious increase in the dose. You can increase the dose by about 25 to 50 milligrams a day if it's well tolerated and needed. Target dose would be about 450 milligrams a day in divided doses by the end of 2 weeks. If you take more than 200 milligrams, you need to take it in divided doses. You shouldn't take more than 200 milligrams at any given time. If you need more than 450 milligrams, then every other week or even every week, you can increase the dose interval by about 100 milligrams, but the max should be about 900 milligrams. You don't get better response over 900 milligrams, but you do get more side effects. Well, at times, the drug can be used intramuscularly, but intramuscularly, it's difficult to use. It's painful. It seems that you need multiple simultaneous injections right at the same time, multiple different sites. Seems to require more stringent monitoring than the oral medicine. It's unlicensed for its short-acting intramuscular use, and unfortunately a depot injection that lasts for a month isn't available, so that means you've got to go through the shots every single day. The duration is the same as the oral medications. It's used for highly agitated patients who consistently refuse to take oral medicines. So it's used as a transition drug until they're well enough to take the oral medication. The effectiveness, unquestionable. Seems to increase the ability to leave the hospital, maintain normal occupation, decrease the relapse rate, increase patient acceptability versus some of the other medicines. And additionally, it can lessen the likelihood of substance abuse in people with schizophrenia. Now, with all of these drugs, they work on the dopamine and serotonin receptors, seem to be antagonistic to the adrenergic receptors, cholinergic receptors, histamine receptors. Seems to work on the GABA receptor, but it carries a black box warning. Black box warning is the FDA's telling patients and doctors alike that, hey, this medicine has some potential very serious complications. Now, black box warnings are present in a lot of drugs. Every single drug in the anti-psychotic family has the black box warning. warnings are for severe neutropenia. Neutrophils are those white blood cells that fight bacterial infections. And in some people, the numbers may fall precipitously, and then you might have some problems. Orthostatic hypotension, it can cause, especially in older people, when you stand up, it causes the blood pressure to fall down, heart rate decreases, and then can cause fainting. Can cause seizures and can cause both myocarditis and cardiomyopathy. Can lead to death from cardiovascular reasons, sudden cardiac death. Lead to heart failure, pneumonia. But let's talk about this neutropenia for a moment. The neutropenia, decrease in the level of neutrophils, can be mild, moderate, severe. Can be so severe it can be fatal. Tends to occur mostly during the first 4 months of therapy. Then the risk decreases. So if you're taking the drug and you develop a fever or weakness or lethargy or sore throat, any other signs of infections, talk to the doctor right away. You should check the baseline blood count, see what the absolute neutrophils are. Then you test them weekly for the first 26 weeks or thereabout. Originally, when it was marketed, FDA said you had to have more than 1,500 neutrophils, absolute number of neutrophils. Then they reduced it in 2015 to, well, you should have more than 1,000 neutrophils. Should stop the therapy if the neutrophil count goes to less than 500 per unit of blood. Well, this orthostatic hypotension, that's another kind of problem we have with the slow heart rate and the syncope. We know that that tends to occur with an early and a rapid increase in the dose, and that's why it's very important that you begin to take the dose at a very low level, 12.5 milligrams once or twice a day. Now, if you're off the medicine, you forget the medicine, you go on a vacation, you do something, you don't have any medicine for 2 days, then you have to start the titration again. And the problem of orthostatic hypotension, the fall in the blood pressure, can be worse if you're dehydrated, if you're taking blood pressure medicines to reduce your systolic blood pressure, if you have cardiac ischemia or heart failure, if you have conduction abnormalities, or if you have cerebrovascular disease. Now, if you develop myocarditis is a problem with the heart muscle itself. It can be associated with chest pain, increased heart rate, palpitations, decreased blood pressure. Some people get short of breath. They have a flu-like reaction with fever, electrocardiographic changes. And we find the chemicals associated with heart attack, troponin level, common blood test, goes up. Eosinophils goes up. C-reactive protein goes up. Well, in those people, stop the therapy right away, of course, and don't restart the medicine. Well, it seems like the myocarditis occurs in the first 8 weeks and the cardiomyopathy after 8 weeks. Seizures are possible with the medicine at a rate of about 5% a year, dose-related. So you need caution if a person has a history of either head trauma or central nervous system pathology, people who abuse alcohol, or medicines that decrease the seizure threshold. Those people seem to be at increased risk. So if you're taking the medicine, and because of the increased incidence of seizures, have to be a little careful driving a car or swimming. Medicine is available by the risk reduction and mitigation strategy. That's the FDA's fancy term for when you get the drug, you have to be registered, the doctor has to be registered, the pharmacist has to be registered, so they keep tabs on who's getting the medicine. Now, if you discontinue the medicine, you do it gradually over the course of 1 to 2 weeks if there's no evidence of a low white blood count, that neutropenia. On the other hand, if you do have a low absolute neutrophil count, then you could stop the medicine abruptly, but you continue to monitor people until the level of the neutrophils gets over that 1,500 milligram threshold, or 1,500 unit threshold. And you monitor them for about 2 weeks to make sure that they don't develop a fever and the count's going up. Well, if you stop too abruptly, then people might have other kinds of symptoms. They might have psychiatric symptoms. There's something that we call a cholinergic rebound, where the people get agitated or confused or have anxiety or insomnia. Sometimes they make excessive saliva. We call it sialorrhea. Or they can develop extrapyramidal symptoms, slowness of movement. Sometimes they develop some profuse sweating and nausea and vomiting and diarrhea and elevated heart rate. Other kind of side effects of the medicine are drowsiness, dizziness, tardive dyskinesia, but less than with other similar drugs. Can cause a decrease in the blood pressure, can cause blurred vision, drooling from excess saliva in about 30 to 80% of the people. So that's significant. Causes problems when you try to sleep. It seems to be worse at the start of the therapy, but if you take some Benadryl and maybe some topical anticholinergic, seems to be much improved. Now, some people also complain of bedwetting or tremor or lack of ejaculation during orgasm. Some people develop headaches or restlessness. And as with all the other drugs in the family, there's potential for abnormal blood lipids, weight increase, abnormal increase in the blood sugar. Have to be careful if you're diabetic or if you have a tendency to develop diabetes. So obese or family history. You monitor people for diabetes, blood tests, the traditional signs of drinking a lot, urinating a lot, eating a lot, and weakness. But most importantly, even though we talk about all these other side effects, the gastrointestinal hypomotility, so it slows your gut reaction. That occurs in about 80% of patients and actually has a greater mortality associated with it than the agranulocytosis. It can cause constipation, fecal impaction, paralytic ileus, cause bowel obstruction, ischemic necrosis of the bowel. So preemptively, it's probably a good idea to take some laxatives and be monitored. Also have to be careful if the eosinophil count, that's another type of white blood cell, if it goes more than 700 absolute count, might be associated with that myocarditis or hepatitis or colitis or pancreatitis. Then on the electrocardiogram, we have to be a little careful of a prolonged QT interval because that might tend to suggest that you're at risk for arrhythmias, sudden cardiac death. So it's worse with low potassium or low levels of magnesium or people with diarrhea. And you got to be careful if you're taking amiodarone, erythromycin, Sotalol, certain antibiotics or diuretics. And certainly if you have a family history of a long QT syndrome or family history of sudden cardiac death, or if you have a history of major cardiac arrhythmias, very, very careful. Other side effects are the neuroleptic malignant syndrome associated with elevated body temperature, with muscle rigidity and altered mental state, increased heart rate, increased sweating. There's hepatotoxicity, cause damage to your liver, pulmonary embolism, cause some chest pain, shortness of breath. Caution if you have narrow angle glaucoma. Interacts with a lot of the drug metabolizing enzymes, so you have to be careful. If you're taking other drugs, check with the doctor before you take drugs. Drugs like Celexa or Paxil or Prozac or Zoloft, drugs like erythromycin or rifampin, Dilantin, Tegretol, the benzodiazepines, Cipro, the antibiotic, St. John's wort, even Tagamet. Now, women who are of childbearing potential, we don't have any good evidence that the drug is safe, so the suggestion is don't use. And if you are pregnant and the neonate was exposed during the third trimester, well, the newborn might demonstrate agitation or hypersomnia, sleep a lot, hypotonia, flaccid baby, or tremor, or a variety of other kind of abnormalities. If you take the drug, you almost have complete absorption by mouth. The oral bioavailability is about 60 or 70%, and it's not altered with food. The half-life is about 8 hours after a single dose, but if you've been taking the drug for a while, the steady state level, well, the half-life is between 12 and 14 hours with a big range of between 4 and 66 hours. It's extensively metabolized in the liver. Major metabolite is Clozapine. That's an active drug. It's metabolized by the drug enzyme, the CYP12A. 90% of the medicine is bound to serum proteins, It's almost completely metabolized before it's excreted. Excreted 50% goes out in the urine, about 30% goes out in the feces. Have to be careful. If you have some sort of either liver or kidney disease, then you decrease the dose. There's no official guidelines for use in the pediatric population, but some people are using it off-label. That's kind of risky. Difficult time in establishing the correct dose. In the geriatric population, they're more prone to that hypotension that we talked about. They have a tendency to have decreased liver, decreased kidney function. They're more susceptible to the anticholinergic effect. So the senior population might have more urinary retention or constipation. And it seems that there's an increased incidence of that tardive dyskinesia, those abnormal movements, especially in elderly women. Now, if you overdose on the medicine, it can cause too much saliva, fast heart rate, sedation, delirium, coma, respiratory depression, can cause aspiration pneumonia, cardiac failure, and seizures. Now, what the fatal dose is unknown. In some people, it's more than 2,500 milligrams, but we know others have survived at more than 4,000 milligrams. Well, clinically, it's good for treatment-resistant schizophrenia. So the Diagnostic and Statistical Manual, that's the American Psychiatric Association Bible of psychiatric disorders, they say if you have an inadequate response to at least 3 different drugs in at least 2 different categories over the period of the past 5 years, then you should consider clozapine compared to some of the other drugs at a dose of at least 600 milligrams, but maximum 900 milligrams. Well, 30 to 60% of the people respond to clozapine once they don't respond to other medicines. Sometimes you need something called augmentation. Sometimes you need other medicine in addition to the clozapine. That drug could be valproate. That seems to be more effective than some of the others. But ECT also seems to be highly effective. Now, if you do have treatment-resistant schizophrenia, the cost to treat that compared to schizophrenia in general is going to be somewhere between 3 and 11-fold more. Now, there are different types of treatment-resistant schizophrenia. There's pseudo-treatment-resistant schizophrenia. Those people are inadequately dosed. They don't take enough drug, or they have enzymes that metabolize the drug very rapidly. About 20 to 30% have true treatment-resistant schizophrenia. And then we have the ultra-TRS. That's a significant portion of the patients, about 40%, and they only partially respond or don't respond to the clozapine. Now, it was once upon a time thought you had to take the medicine for 3 to 6 months to see what the results were. 6 weeks, you'll know what the result is. And it seems that it can decrease the recurrent suicidal behavior. So it seems to delay the time in those people who really seem to be at risk. So people who have made an attempt within the past 3 years, people who have been hospitalized within the past 3 years in order to prevent the suicide, people who have moderate to severe suicidal ideations, they get the hallucinations, the commands, the voice within to commit suicide. Those people seem to do better, decrease the rate of recurrent suicide. Now, the clozapine improves both the positive and the negative symptoms of schizophrenia. Positive symptoms, hallucinations and delusions. Negative symptoms, withdrawal and the poverty of speech. History is it was synthesized in 1956. It was based on imipramine, first tested in 1962. Seemed to fail. Then in 1972, it was released in Austria, and Switzerland. A couple years later in West Germany and Finland, but it was voluntarily withdrawn from the market in 1975 and out of favor for at least 10 years because studies in Finland showed about a 20-fold increase in the rate of agranulocytosis, the decreased level of those granulocytes, or the white blood cells, that are associated with an increased incidence of infection. Well, that seemed to be mostly the people in Finland. It seems that the incidence in the rest of the world is considerably less, as I mentioned. Well, if you do take the drug, 100 milligram tablets, 90 of them, going to cost you cash anywhere between about $70 and $300. With a coupon, it's $40 to $60 for a month, unless you go to Walgreens where it's about $83. So it's a drug that's highly underutilized right now. Unfortunately, there's a lack of doctors who feel comfortable with using the drug, but there's a great mismatch when we talk about the efficacy of the drug, how good it is, how good the results are, versus its utilization in clinical practice, where not too many people are using it. And remember, the higher the level of the baseline psychosis, the better the outcome with the medicine. Clozapine seems to be an option, especially if you have treatment-resistant schizophrenia, schizophrenia in general, suicidal ideations or attempts, and maybe off-label for treatment-resistant bipolar disorder with psychotic features. So those people with bipolar disorder who have hallucinations and delusions. But overall, the drug's not terribly popular, but it's cheap. And none of the big pharmaceutical companies advertise the drug. But if you look at the drug compared to those drugs that are highly advertised, this seems to be pretty effective. But we have some side effects. And the side effects, especially the gastrointestinal side effect, the constipation, that can be a major issue. Small percentage of the people who are going to develop those low levels of the white blood cells that fight the bacterial infections. Both can be troublesome. Both can lead to fatal reactions. But if they're adequately addressed prophylactically, we know that we can use the drug fairly safely. Then we have the usual complications that are associated with all of the anti-psychotic medicines. And don't forget, this drug has significant indications, but we tend to overlook it. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.